So how will the presentation will be? We'll be having a first introduction of the drugs about the topic. Then we'll to not to bore everyone, we'll have some case scenarios. We have a discussion on those case scenarios.
And we want active
What
participation.
drugs?
Yeah.
Yes, we want active participation. We'll be looking forward to answer all your queries. Probably at the end, but we'll try. Alan, we can try doing it alongside or no?
Yeah, we can try doing that. So we'll try and keep this session as much as possible, more of an interactive kind of picture.
Yeah, there are basic case scenarios which you see in an emergency on a routine basis. So I've put only the basic case scenarios, what drugs to be used, how will you manage when you're doing a ICU duty, how will you intubate a patient. All these case scenarios are routine things in every health professional's routine.
Hi, good evening, all. I think 2 more minutes we'll have a start, and I hope you all have made yourself available for the amazing session which is going to unfold in front of you in another 2-3 minutes. Please bear with us, and thank you. Well, great. Good evening, each and everyone. I am thrilled and welcome you for today's informative webinar on essential medicines, what every healthcare provider must know. I am Vijay from Mediversal Academy, and I have privilege introducing you to our esteemed speakers for the day, Dr. Alen Thomas and Dr. Ankush Goyal. Now you already know the persons we're talking to you guys. Though it was a very small session, we had an amazing information gone through. It was like an index to the whole webinar. So having all said that, I would like to introduce Dr. Alen Thomas to you. Dr. Alen Thomas is an MBBS graduate from CMC Vellore, furthered his education with a master's in general surgery at CMC Ludhiana. Currently working at CMC Vellore as a junior faculty, he has initiated his career in resource limited region of Uttarakhand and UP, showcasing a strong commitment to excellence. Driven by his dedication, he earned a PG diploma in family medicine from CMC Vellore. Specializing further, Dr. Alen completed a PG fellowship in vascular surgery, earning a FMAS, that is fellowship recognition from AMASI. A proud member of ASI, AMASI, and CMAI, he is also recognized for his prowess as a presenter, having been awarded Best Speaker at CARES 2002 Ludhiana. Talking about Dr. Ankush Goyal, he is a MBBS MS General Surgery from CMC Ludhiana, renowned for his exemptions achievements. Dr. Goyal was recognized as the best outgoing resident doctor his tenure. Currently serving as a senior resident at AIIMS Jodhpur, Dr. Goyal plays a pivotal role in managing a spectrum of complex surgical and trauma cases. His expertise and dedication exemplify the highest standards of medical care, making him a distinguished figure among his peers. He has been a wonderful teacher and is known for his specialty in simplifying difficult medical topics. Over to you, Dr. Allen and Dr. Goyal. I hope this session is going to be a great. Over to you guys. Thank you.
Thank you. Thank you, Vijay. Thank you for joins. Hi, Dr. Allen. Hi. Good evening, Dr. Allen.
Hi, Dr. Ankush. So Dr. Ankush has been a good old friend of mine, and he's been a government doctor. So I had invited him for this presentation, and he has a very good insight about this topic because it's, of course, essential medications, right? So what every healthcare provider should know. Okay, so it's a national list of essential medications by Government of India. So we have a quick, theory, and we have some case scenarios waiting. And I'm really excited to go ahead and start this presentation. And I hope many will be benefited, especially for our friends and mission hospitals who are all by themselves and handling many cases together. And all the very best. And so just going to start. Can we start, Mr. Vijay?
Yes, we can start. We can start.
Great. And somebody's trying to draw on the screen. Vijay, can you take care of that?
Yes. Doctors, please don't use that annotate option. That will create a problem. Yes, I have told them. I'll try to get it done from my end. Thank you. You can
Sure.
continue.
Anyways, we'll proceed. And yeah, great. So this topic, essential medications or medicines, what every healthcare provider must know. And it's for rational and affordable healthcare. I'm Dr. Alen, and I have Dr. Ankush with me. We'll be presenting together. So if you look at the definition, so essential medications are actually those that satisfy the priority healthcare needs of the population at all times. So it's not my definition, it's by NLEM, and it's very simple. Priority healthcare needs of the population at all the time. So those medications that handle the healthcare. So we will try to learn also together. It's a very important question for those NEET participants also about NLEM, and you can get a question on that. So what is the selection criteria for essential medication? So you should understand that there are selection which drugs will make it to a list. There's so many drugs. So essential, and each drug maybe have a good predominance to that particular area. So right now we're looking at NLEM 2022 by Ministry of Health and Family Affairs. So we have the selection criteria here, which says the disease prevalence. So based on the disease prevalence of that area, of that region, of the country, you have essential medications to treat that. And public health relevance. So is it really relevant in the large sector, in the public health area? And of course, the medicine or the drug that you're using is what is the evidence of the efficacy and the safety profile of that drug. So it is very important to know that. And yes, comparative cost effectiveness. You may have a drug that's very expensive, but you may even have a generic drug which is doing the same function but at a much comparable cost. So
yes, Alan rightly said, cost effectiveness is the point. Okay. have a lot many drugs available in the market, but cost effectiveness is the main thing which is to be focused on.
Great.
Sorry for
Thanks.
interrupting you, Alan.
No, that's perfect. And I would definitely love to have your inputs, Dr. Ankush. So, yeah, the purpose, what is it? So, first we look at the selection, then we look at the purpose of essential medicines. So, purpose of essential medicine is yes, the drug should be available in adequate amounts, in appropriate dosage forms. Okay, and definitely the strengths with assured quality. You cannot compromise on the quality and the adequate strength that is required. And again, as Dr. Ankush rightly put forward, definitely at an affordable price. So, what is the concept of essential medications? So, we are looking forward for a better healthcare and a better drug management, definitely at lower cost. So, how did the government try to implement that? What is implementation? Implementation is actually the concept of these essential medications is intended to be flexible, adaptable to many different situations. Okay, exactly which medicines are regarded as essential remains a national responsibility. So basically, these drugs are there. You need to implement these drugs, and it is a national responsibility of the same. So, what is the history behind the WHO model of essential? So, why we were still not talking about NLEM, but then now we look at suddenly this WHO model comes in. So, the NLEM was actually inspired, really inspired by a WHO model list of essential medicines. So, if you look at the model is essential medicines by WHO, which was initially Cuba, who possibly pioneered the concept in 1963. However, if you look at data, the official national list of essential medicines was introduced by Tanzania in 1970. Even though Cuba pioneered it, however, the official notification came in 1970. 77, the first model list was published by WHO, comprising of 212 drugs. The latest is not 2022. Of late, it is 12. I apologize. The latest is the WHO model list is 2023. Yeah. NLEM is the 2015, and then 2022. So, what are the criteria for selection? Quality of the drugs, pattern of prevalent disease, cost, and the benefit risk ratio. We'll move ahead. So, when two or more drugs are therapeutically, they have an equivalent preference. So who should you give preference to? With the drug A and drug B. So they say both are therapeutically equivalent. When both have the same function. So so how do you say, okay, I will be adding this drug to the list? So we look at something a better understood or better studied drug. One drug may be used for multiple diseases. So treatment of more than one condition or disease, that's a clinical utility. The pharmacokinetic profile, I believe there are definitely pharmacologist students and pharmacology faculty here for listening to this lecture. So pharmacokinetic profile, you'll very well understand. The favorable ones will definitely get picked up. And stability under local anticipated conditions. With many, they may not need much of a storage issue like cold chain or something like that. So if you have a local anticipated conditions, favorable stability, that drug would get picked up. Then local reliable manufacturing facilities should exist. So the drug should be available in adequate quantity to our people in the country. It should not be in shortage. So the drug that's available in a good quantity with the similar profile will get chosen. So dosage forms now, how do I choose the dosage forms? General utility and wider availability, of course, and the number of preparations is the minimum. So we don't want too many preparations and all that dosage. So those kind of things get picked up for the selection of essential medications. So financial resources, about 20% of the total expenditure on the health is spent on drugs. So you should understand that. And environmental factors, mortality and morbidity statistics of the drug should be studied. It should not be harmful to the much harmful to the human body. The risk-benefit ratio. And of course, this selection should not be like once you make a list, it should stop. So this should be an ongoing and a continuous process where some drugs get added and some drugs get deleted. Essential medicines should be rationally developed. You should not add these, as many pharma companies do nowadays. They add multiple drugs, maybe rationally evident or may not be, but then should always look for rationally developed treatment guidelines. Now, what are the advantages of this essential medicine list? Of course, you need to know that they're more cost-effective drug control management, purchase, storage, and distribution. Cost effectiveness really plays a big role in selection of the drugs and improvement. Because if you have one of the good drugs, but if the patient cannot buy it, the drugs will just rot in the store. So yeah, so that itself is very important. If you want to reach to the masses, then definitely you need to have a cost-effective drug. And simplified, and more importantly, the drug information should be clearly mentioned, and the formulation should be from the preferably from the local drug formulation and production. So creation of monopolies favoring a single drug product should not be there. So that what happens is, because of a single drug being selected, there are possible monopolies are also there. So if you look at drug companies and all, some drug companies are very well, they're more of patient oriented, and even though they provide only single drug, they definitely try to keep it on a really low budget. And of course, reduce this one, lack of interest for drug innovation. So what are the core list and the complementary list? Of course, NLEM does not have this core list and complementary list. This is taken from WHO's essential trick. So we are actually, juggling between WHO and NLEM, but we will focus mainly on the NLEM. But there are some key points which will really help you understand the NLEM from the WHO. So that is why we've, merged both of them. So core list is for basic diseases, basic healthcare system. You need to have these drugs. If you're starting a hospital, the core list drugs should be available in your pharmacy. It is efficacious, safe, cost-effective medicines for priority conditions. Complementary list is for complicated diseases, okay, and that require a specialist intervention, specialist prescription. So those drugs and may require further monitoring and all that. So that is not really needed when you start off. But yes, if you're planning to have those facilities, especially in the cardiac care, anesthetic care, or palliative care, then definitely you need to have, from the complementary list, you need to have drugs, and definitely a specialist training is needed, and definitely some licenses. So rational use of drugs. If you look at the rational use of drugs, let's look at a scenario where you are sitting in your OPD and you have a patient who's told you 5 symptoms, and you choose from those 5 symptoms, yes, I'm going to fix onto 1 or 2 drugs. So you need to definitely understand the disease pathology, and then yes, which disease will be treated by which drug. So yes, the correct drug, appropriate indication, the dosage should be important, safety profile, and preferably no contraindications. But may or may not be possible all the time. But you should try your best if there are contraindications. Something known as contraindications, and there are relative, absolute, and relative contraindications. And yes, correct dispensing is very important. Your dosage should be correct. Dosage is not right, then it will be difficult. And yes, patient's adherence to treatment is needed. So,
Alan, I'll interrupt you. Sorry.
Yeah.
In this, I would like to add up on, as you said, the safety profile. Uh,
You're not audible, Ankush. Hello, are you there? Hello, Dr. Ankush. Sorry, you're not audible, Ankush.
Hello. Hello.
Yeah, Ankush, are you there?
Yeah.
Now you're audible. Now you're audible.
I think there was some glitch in my internet connection. Yes, Alan, I'd like to add up to this thing, what the rational use of drug. There's a list as already Alan explained well that how to choose one drug. I would like to add up on the side effect profiles. Suppose within the same class there are different drugs which have different side effects. So we need to choose that rationally. Suppose you are giving one drug which already has a side effect profile, side effects of gastritis, vomiting, and patient is already having gastritis symptoms. So you can't choose that drug. You have to shift to another drug. So keeping in mind the side effects also, you have to choose a drug. So Alan, you can continue now. Thank you.
Great. And definitely your drug should, should not have, the patient should adhere to the treatment of the drug. And it should not be like you prescribe, but the patient is not taking the drug, then you will not have any, benefit. So just as some examples of irrational drug use. So prescribing drugs of no proven value just because your medical representative has come to you and said, "Sir, can you please prescribe these medications?" It does not do any harm, but it may or may not have a benefit. So no proven value can add just the cost. No drugs are free. So definitely, no proven value. Sometimes you just go blind and prescribe empirically. So empirical treatment, definitely when the patient is sick, okay, is hypotensing, you're sick, then you may have to hit hard and then de-escalate as per cultures. That is what microbiology teaches us. So unnecessary prescribing of self-limiting conditions and overdosing or underdosing. So you should be very well, even if you are doubtful of the doses, go back, check once, and then prescribe. And of course, when you prescribe costly drugs, you better be careful what side effects they have, and you should understand that many patients do spend a significant amount of money prescribing your prescribed drugs, buying them. So it's very important to understand, as per some study, it said that for a person who is just at the poverty line, one disease is enough to bring the patient below the poverty line. So if you prescribe more costly drugs, then definitely he will have to sell his, if it's a rural setup, he may have to sell his animals, he may have to sell his house, his land, just to, get treatment. At the end of the day, for what? And the patient also may not even recover, may recover or may not recover. But if you're so irrational drug use should be avoided. And when oral drugs are sufficient, many places, rural India, I worked in a couple of places in rural India. Patients just come to me saying, "Give me that injection." It might be just a vitamin B12 injection, and suddenly they feel after 5-10 minutes. Whether it's all in the mind or not, I'm not sure. But when oral drugs are available, avoid injection because they can definitely have side effects. The injection site may develop some abscess and cause further problems. Yeah. So we thought, okay, we'll just take a quick break, and Dr. Ankush will have some lovely case scenarios. Let's just refresh our minds and keep our chat boxes open. So I have my chat box open here with me, and over to Dr. Ankush. You can start off with case scenarios.
Yeah. Thank you, Dr. Alan.
So I will keep interrupting and informing what the users are, informing.
Yeah, sure. Okay. So nice presentation by Dr. Allen about the introduction of LEM drugs. These are the basic drugs everyone should know how to use based on the side effect profile, based on the different uses, the contraindications. So now we'll come to the case scenarios. These are very basic case scenarios which we see in a primary health care setup, or maybe when we are working in ICU. So I'll move on to the first case scenario. Alan, I think I am not able to move the slides.
You want me to just try again? 1 second. I'll just give you the access again.
Sorry, guys. I just want
slide control. Yeah, go ahead. Ankush, just try.
No, Alan. I think there's a problem. Alan, can you do it for me?
Sure, I'll do it.
Oh, so first case scenario. There's this young 22-year-old male who presented to your hospital with alleged history of road traffic accident. So this is the accident he met with. He's a young male. He came with RTA to your hospital. So next slide, please. So you examine this patient. This patient is drowsy, vomiting. There's incomprehensible speech, and there's generalized extension posture. So this is the GCS you calculated the patient from this history. You calculated the GCS of the patient. You took vitals. Vitals. The patient is having unstable vitals with heart rate of 110, BP 80 by 60. Uh, Dr. Allen, this patient has low GCS, unstable vitals. So, what you would like to do the next?
Hmm. That's a good question. Let's put it to the audience. You can just quickly put in the chat box. I have it here,
Yeah,
and I can just read out.
I'll repeat again. Young male with unstable vitals, drowsy, low GCS. Yes, I got a reply. IV fluids. So let's go in a order. There's something called as ABC of trauma. A is always airway. Always you look secure your airway first. Then you go to the breathing part. Then last is the circulation. Circulation is putting IV fluids. So yes, someone has rightly said ABC. Stabilizing the spine it comes along with the airway. When you're securing the airway, you make sure that the spine is stabilized. Next, Alan. So keep this scenario in mind: a young male, unstable vitals, low GCS. So how will you secure the airway,
Though
Dr. Allen?
Kirti has mentioned low GCS suggests to intubate.
Yes, low GCS just to intubate. So Alan, next slide, please.
Yeah.
So, what drug will you use for intubating this patient? He's a young male. I am repeating this case scenario. A young male, low vitals. We have assessed the GCS. So now we want to intubate this patient in order to maintain the airway. Anyone? Diazepam? No, 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 not diazepam. Diazepam, I don't think it comes in an IV formulation, but diazepam is not short acting. Sucol, yes, Sucol is a drug which we use. It's a muscle relaxant. Propofol. Uh, Most of the
Hello?
people are saying propofol.
Hello?
Propofol will not
Hello?
use because the patient is already having a low BP. Patient
Hello?
already has unstable vitals.
Hello?
I think someone has turned on the mic.
Uh,
Yes,
Yeah,
Dr. Allen.
this is going on interesting. Yeah. So you have so many drugs in the crash cart, safely intubate. So the midas. This is all from the chat I'm reading. Propofol, scoline,
I'll tell you the
atropine.
answer. I think we'll probably use ketamine for this patient because the patient already has a low BP. BP is 80 by 60. So if we use propofol, if we use midas, this will further decrease the BP of the patient. So it's better to use ketamine. Ideally, etomidate is the drug which is to be used, but I guess it's not available at a primary healthcare level. So we'll use mifentrin. No, no, no. We will not use mifentrin. We will use ketamine. Alan, next slide, please.
Yeah, small power outage on my side. Just sorry, not expecting it today. Just a second. Vijay, can you just, Dr. Ankush, can you just play the slide from your end?
I am not able to play the slide, Alan. Dr. Alan? Yes, yes, I am able to.
You can?
Yes, Alan, Dr. Alan, I am able to. I'm losing the control in between. Sorry, guys. Sorry for this glitch. Dr. Alen, are you moving the slides?
Dr. Ankush, can you proceed?
Hello, Dr. Alen.
Do you want me to share screen if you can?
Alan, your mic is mute.
You're back in cloud. Please proceed, Dr. Ankush.
Hello. Yeah. Dr. Alen?
Yes,
Can we
yes,
go ahead?
I'm here. Please proceed. Yes,
Yeah.
please.
So this was a young male who presented with RTA. Uh, presented to the RTA. So we need to, he was having a low GCS, a low BP. We need to secure the airway. So we secured the airway by intubating him. What drug was to be used was the question. Since low GCS, low BP, a drug of choice would be ketamine or etomidate. Someone asked about the dose of ketamine. The dose of ketamine is zero point 0.1 to 0.5 mg per kg. Depends upon the patient. Why I'm using ketamine is because we have already assessed the GCS. Ketamine is known to cause emergency delirium, which will we have already assessed the GCS, so we need not further assess a GCS. So we can use ketamine safely, and it's available at a primary health care level. It's available. In fact, etomidate might not be available. It's a costly drug. Next slide, please. This is
Yeah.
the list. This is the NELM list of the drugs. This is not an emergency drug. These are inhalational drugs: halothane, isoflurane. Ketamine is an IV drug. Nitrous oxide is also an inhalation drug which we use in OT. Propofol is routinely used for GA cases in OT. Sevoflurane is used in children, is an inhalation drug, and thiopental. Thiopental is also a drug can be used for rapid sequence intubation. But I guess thiopental is not readily available at a primary health level. I'm not considering tertiary care or district hospitals. I'm talking about primary health. So these are the drugs.
Just to add on, as you can see, this level of healthcare, PST means primary, secondary, and tertiary. So ideally, these drugs should be there, but we don't know. I mean, whether they are stocking it or not. But as per the NLEM, if it's sevoflurane is SNT, means secondary level and tertiary level. If you look at thiopentone, primary, secondary, and tertiary level, and it's available as powder for injection.
Yeah.
Can we proceed to the second case scenario?
Yeah. Second case scenario. So first we are ended. This was a trauma case. Now this you are sitting in a OPD, a 60-year-old male with a history
Sorry, before that, sorry, Dr. Ankush, before that, anybody has any further, comments on the first scenario? Can put in the chat box before we proceed to the second. Right, no worries. So let's proceed, Ankush.
Okay, we'll proceed. There's a 60-year-old male, a elderly male. You are sitting in a OPD. You see a 60-year-old with a history of cardiovascular event previously. Now he has come with a swelling over the back since 4 years. It's a non-tender swelling. It's a non-fluctuant, and it's you diagnose it to be a lipoma. So you decide to remove it into OPD itself under local anesthesia. What is the drug which will you use, and what precautions will you take considering the age and the comorbidities? The
We get a lot.
The points I want to take into consider is an elderly with a history of CAD. There's a lipoma. You want to use a you want to use a local anesthetist.
So you kind of gave away the answer, but that's okay.
Yeah, but the catch point is You will use a plain lignocaine or a ADR lignocaine. I see the most of the people are saying ADR lignocaine. I want This is the common mistake we usually make. We may land up into trouble. I already said he's an elderly with history of CAD, coronary artery disease. So you
Yeah,
don't
just
want to give adrenaline to such patients. The
definitely.
adrenaline you give, it will pace up the heart. So you are doing a simple lipoma excision in your OPD, and you will land up with a patient having tachycardia or going into arrhythmias. So simple, go for a plain lignocaine. Okay, next, Dr. Alen, next slide, please.
Definitely. Definitely. Just want to add a point. This kind of swellings we see in almost everyday OPD. But, we may or may not even delve into the history. Does the patient really have a heart disease? Here, at least the patient told you. So we should also ask whether the patient has a history of heart disease or not. Before
Yes,
the
there's
procedure.
where history taking, even for a small swellings, history taking is utmost important. You need to ask about the previous history, family history, everything from the patient, even if you are dealing with a small swelling, a small lump. So here you can see the patient has coronary artery disease. The moment you give lignocaine, the patient might land up in arrhythmias. So we'll move next, Dr. Allen, next slide. So the answer is lignocaine without area. It should be a plain lignocaine. So my next question is, it's a big swelling. It's a big swelling. So what's the maximum dose of lignocaine you can use, considering you are using it with ADR, without ADR? Anyone? I know it's a difficult question, but it's a 2 cc. I guess 2 cc, 2% is the formulation which is there. I don't know. Dr. Allen, I will move to the next slide, please. I'll tell the answer. It's 3 ml per kg.
0.4 mg per kg. There you go.
Oh, this is from the basic textbook Bailey. It says lignocaine can be used as 3 mg per kg. It's not ml, it's 3 mg per kg. So if I rough it around, for a 60 kg man, you can use up to 30 ml. This is a rough estimate. This without ADR, you can use up to 30 ml for a 60 to 70 kg man. When you are using it with ADR, you can use up to 70 mg per kg. So you guys need to be
7
yes,
mg
someone
per
rightly
kg.
said
7 mg.
someone rightly said, yeah, 7 mg per kg. I'm sorry if I said 70. It's 7 mg per kg with adrenaline, and lignocaine is 3 mg per kg. Rest of the drugs we rarely use, but I put just for the reference bupivacaine. This is
They're
used
mostly used in operation theater under the guidance of an anesthetist, not in the OPD. Preferably not in the OPD, because
yes. So
OPD
we
may or
use
may not have your cardiac arrest services in case
yes.
a patient
So
arrests.
we use mostly lignocaine. Bupivacaine is used for in gynecological obstetrics. We use when we are given this blocks to females. Prilocaine is used for kids. Ropivacaine is a local anesthetist we use for rapid sequence, and levobupivacaine is a replacement of bupivacaine because bupivacaine is a cardiotoxic. I want you to just concentrate on lignocaine. Lignocaine without ADR, 3 mg per kg, which is approximately 20 to 30 ml for a 60 to 70 kg man. With ADR is 70 mg per kg, 7 mg per kg, not 70, 7 mg per kg. Am I clear, Dr. Allen? Anything anyone wants to ask regarding this case
Yeah,
scenario?
so Dr. Lakshay has put in a good point. In OPD, we can't perform any minor or major surgery. The point is well taken. We need to refer the patient to surgery department. Surgery department OPD usually has a small, called a dirty minor and a clean minor
Minor OT,
area where
minor
they
OT. These
usually do
procedures can be
minor
done in a minor
operation
OT.
surgeries. Yeah. So maybe under the guidance of the surgery registrar or somebody, you can if you're not set up where you have a surgery, you can always request him, because once you're to guide you, or maybe you can take training under them just to see, observe, how these minor cases. Yeah, because surgeon may not be available at all places. So maybe when you're in your utmost village and you need to, some patients may come to you, you may or may have to help them. So yeah, then they may not go to other cities or something. So in case
Yes.
it's a very small gap, you need to have a basic knowledge of these things. Our main idea behind these lectures is to sensitize you to the common problems of our nation, and of course, you are the salt of this, of India, and definitely you need to. You are the ones who are really giving the best medical care at many places where a lot of specialists don't even think of going to the main villages and everywhere. So you are not having a good medical knowledge, you will do more harm than good. So even if your heart wants to do good, you may, because of lack of knowledge, you may end up doing harm. So you should know these kind of basic things. And yeah, so this is what our main thing is.
There's a point put up, Dr. Allen, by one of the participants that there's mostly suturing done in periphery. Yes, there is mostly suturing done. Let's take it that this is a case scenario that there's a laceration. So what's the maximum dose of lignocaine can be used? What type of lignocaine you should use? So you should ask a history. History first. If the patient already has a cardiac disease, you can't use the ADR. Otherwise, you can use ADR. Then what's the maximum dose? Suppose it's a big laceration. So you have to decide whether to, can you do it in a local anesthesia, or you need to take him to theater and give a short GA. So that's how this is case scenario is supposed to deal with. I hope it's clear.
Yeah, perfect. So what happens? You have to wash the wound. Definitely, you have to wash the wound, and at the same time, no, it's just the lignocaine that you're using. You should always aspirate and look for if there's a blood in the hub when you're aspirating. Do not inject, because you would be in the blood vessel near the lacerated wound, and that can cause arrhythmias. All right, and
Yes.
that is very important thing. You should know that when you're doing using a local anesthetic, always aspirate. If there's no blood, then only inject the local anesthetic agent. And it has a time frame, and of course you need to finish your surgery in that, and definitely wash the wound. And if it is in certain areas like your tip of fingers, tip of the nose, earlobe, you should always use plain lignocaine, because if you use ADR, the lignocaine with ADR, these are all end arteries. The end arteries will constrict, and you will have that part gangrene, becoming a gangrene.
Yes,
So you
Alan.
don't want that. So use plain lignocaine to be safe.
Yes,
In
this
those
is
areas, tip of
mostly
toes,
used in
leg.
circumcision. These circumcisions done at a periphery, they use local anesthetics with ADR. Ultimately, they have what is something called as glans gangrene. They ultimately land up into glans gangrene. So you need to be careful.
Because the
when
only
you...
one artery supplying that area.
Sorry, Alan.
Single
Sorry.
artery supply that area, and that artery constricts, then it will be a problem. Yeah, and it is known to constrict the blood vessel. Yeah, shall we proceed?
Yeah, Alan, any questions from the listeners?
Yeah,
There's a
that's what
question.
we'll answer the questions as we go.
There's a
Why we
question.
use lignocaine with ADR? Dr. Shivansh.
Yeah, I'll answer that. What happens is when you give ADR with lignocaine, the time frame of the action of the drug prolongs. This is because the drug which you have injected into the tissue will get reabsorbed slowly because of the constriction of the vessels. So the time duration you get with the local anesthetic using a ADR is more as compared to the plain one. So that's why we
The duration of
use
anesthesia. Yeah, great. Yeah, shall we proceed? Third case scenario.
Third case scenario. So you are working with the gastroenterologist in your town. He's performing an endoscopy, but he's not able to. Sorry, this is a typing error. He's not able to perform it with the ease, and the patient is very restless. So he asked you to sedate this patient so he can do the procedure with ease. So there's a patient, you are doing a therapeutic upper GI scopy, you are assisting a gastroenterologist who has come to visit your hospital. So you want to sedate this patient. So what drug will you use? Someone has said propofol.
Dr. Twinkle has mentioned propofol.
Propofol. Someone is going scoline. Propofol will directly, you can use propofol, but you need to have a person who can intubate. Yes, someone said midazolam. Midazolam is the right answer. We'll use benzodiazepines. Dr. Allen will move next.
Yeah.
We'll use midazolam. Considering the patient needs to be woken up and sent home the same day because he's just undergoing a upper GScopy.
Short acting.
Yeah.
Short acting.
Short acting. It's a short acting benzodiazepine. So we'll use midazolam. Dose is 0.5 to 1 mg per kg. The vial which comes is 1 mg per ml. So in this, we need to be sure that patient be aware of the saturation of the patient and look for any aspiration. As I already said, we need to protect the airway. Maximum dose, I would suggest don't give more than 5 ml. Try start
5
with
ml.
5 ml. I am saying ml, which means 5 mg. The total
Vial
dose
comes
this is
as
the
1
total
mg per ml. And don't give off 5 ml in one shot. Try to give
don't give a
one.
5 ml in one shot. Just go ahead, give 1 to 2 ml initially, and you can later add on 1 ml per injection. Don't give 5 ml. I know it's a general practice. People straight away give 4 to 5 ml. I'm saying ml. On the first shot, it's a dangerous thing, very difficult. Sometimes it can get very complicated. I have seen my residents giving 4 to 5 ml for a trauma patient. Ultimately, patient came walking. Ultimately, patient had to be intubated and shifted to ICU. So always use 1 to 2 ml. Just the dose is 0.05 to 1 mg per kg. It's 0.1 mg per kg. The vial which comes is 1 ml per mg.
1 mg per
ml. 1 mg per ml. If the patient has history of alcohol since 30 years, so please suggest midazolam dose. Yes, this is a right thing. Right
common
question.
problem, I think.
Common problem.
I know
Common problem.
Dr. Ankush. I know Dr. Ankush has worked in trauma for a long time at
Yes,
AIIMS
patients
Jodhpur.
do.
Has seen multiple trauma. So
Yes, patients
alcohol-induced
do become
trauma and all that.
overdrunk.
Yeah.
So what we usually do is we try to avoid midazolam. First of all, the person who has asked the question, I'll tell the in other if even if after not avoiding you are not able to do, you need to give it. I would suggest only 0.05 mg per kg. That is 1 to 2 ml only. Don't give more than that because these patients are at high risk of respiration.
Right. Very right. In
Dr.
my
Allen, you are there.
practice, yeah.
So these
So in my practice, Dr. Ankush. So these alcohol patients sometimes they come so drowsy, we may not even need to give anything. You can intubate like that only. That is also there.
Yeah, that happens. This is a OPD scenario, Dr. Allen. There is a gastroenterologist performing a GScopy. So in
Yeah.
emergency, we don't give midazolam because patients are already drowsy.
Yeah. So we'll
Any questions from this?
Yeah, 3 scenarios. We'll have more scenarios coming up shortly. Before that, I'll just take over.
Alan, there's a question. Can you please, sir, there are special precautions or contraindications to keep in mind. I can't read the question.
Sir, are there any special precautions or contraindications to keep in mind while sedating a restless patient for endoscopy?
Yes, I already said you need to keep the airway, a look at the airway because these are sedative drugs. The patient might aspirate, and you have to, when you're giving midazolam, you always have to use oxygen. Whenever you are giving a patient midazolam, always put a patient right away on oxygen. By default setting, put on oxygen and then give the drug. These patients,
right, very right. So,
yeah.
So,
Dr. Allen,
great.
continue.
So, thanks, Dr. Ankush. Yeah, you will have a couple of more scenarios, more exciting scenarios towards the upcoming slides. before that, I just wanted Vijay to just have a quick 1 minute kind of a break because it's been such an intense session. I love the participation of the candidates, and Vijay, can you just give us a quick break and just let us know about Mediversal, who is organized this entire program for us. Yeah, over to Vijay quickly.
Thank you, doctor. Thank you so much. I've been listening to the whole session, and it is all so
We will
informative.
continue after Vijay. So a quick break. Yeah,
Yeah,
just a water break.
yeah, great. So the session so far was so good, so informative. I'll just take 1 more minute. Like I'll finish it up, and we'll get back to the session as early as possible. So about Mediversal, Mediversal Academy is a premier institution dedicated to providing high quality upskilling and reskilling program, specifically tailored for medical professionals, including MBBS, BAMS graduates. Our mission is to enhance the capabilities of healthcare providers through structured, flexible, and comprehensive education modules. Our core features are we have four type of learning methods where we have our recording sessions, we have our dedicated LMS and live webinars. We also conduct case series in social medias where we give certificates those who give right answers on a daily basis. So we also have around 30 to 40 plus and growing daily clinical attachments pan India for MBBS and BMS candidates. If you want to have a clinical attachment anywhere in India, please reach out to us. We will arrange that on a priority basis. Also, the network is growing now. Around we have under 30 plus on the pipeline. We already have around 40 to 50 plus, I guess. Right now, clinical attachment, even for BMS, you are allowing that. And we also have programs such as PG diploma, fellowship, post-graduation programs, advanced certificate courses, and certification mastery courses. All these courses are 0% EMI. Like, for example, zero cost EMI. All these courses can be availed from Mediversal Academy for 0% interest. You can pay us on a monthly basis and still can learn from Mediversal Academy. Also, one more thing that I don't know about others, but what we provide is we also let our users download the content from our LMS. The PDF part from our LMS can be downloaded and kept with you for lifetime. I know because when you take any courses from us, the courses will stay for 1 year. That 1 year time surpasses, then you will have no access. You might not have access to LMS, but the downloaded PDF, you will have it for the rest of your life. Where I know your experiences, the moment if you have a glance on the PDF, it will all come back to you. So just to make sure that happens to all our alumni, we have made sure that LMS will allow you to download PDFs. Please reach out to us. I'll be pasting the link of our browser. Please go through it. Any courses you need, please reach out to us. And one important thing today, you can use code called Alen 10 to get a 10% off on all our courses. Please utilize this opportunity and get back to us. I will drop two things. One is our course brochure where you can avail about our about Mediversal Academy. I'll be dropping in the chat box. And I'll also leave you a link where you can give us information about yourself so that we will be able to call you back and get this offer to you. And also you can have a free counseling about what courses you need to do. I'll also leave that link on the chat box. Please fill that. We will have you call and we will give you a free counseling about our courses. And one more thing, yeah, cross voucher has been sent to you. Yeah, great. So to summarize everything, Mediversal stands with doctors to upskill and reskill them on all the aspects. We have around 40 plus courses up and running on our LMS. We have from cardiology to oncology to rheumatology, sports medicine, sexology, everything. We have around 40 plus courses. Also, we are ISO certified We also have accreditation from ABAS USA and NSDC India accredited. And I also know one more thing, that there is something called CME, Continuous Medical Education. To promote CME, we have signed up with Up to Date. And Up to Date is a digital library where you can learn on a daily basis. And every question searched will fetch you a 0.5 points. And you can gather all these points. Once you have a bunch of points, you can claim this against certificates from all over the world. These certifications are not from Mediversal. This is from world biggest organization, like from England, Royal College of Medicine, Royal College, such big names from Australia, from England, from USA. There are so many certificates you can claim against this point. So reach out to us, get the admissions, and Up to Date will be on the package. You can learn on a daily basis.
Wow.
Yeah, thank you.
Up to Date is a
Yeah.
very good tool. Even after your post-graduation.
We have used a lot of Up to Date.
Yes,
And
Up to Date
during
is
our PG time, and even after PG on a daily basis, Up to Date. But it is quite expensive, Vijay. I believe if you could make it free with the courses as a request, it's very expensive, but I think Mediversal will make it free when you enroll for our courses. So, as a part of the course, for you to learn more and more, because our motive is to make you guys learn the best and from reliable sources, and you should have references to what evidence-based medicine is what is the latest trend of these days. So you should learn from the best. So we have tied up. I think Mediversal is tied up with Up to Date, and yes, that is the best, I would say. And Mediversal, I would strongly request Vijay. Since a lot of participants are here today, I'm so happy to please give it free of cost, absolutely free of cost, whenever they enroll for our.
Sure, done. What we'll do is, anyone using this code today, I have entered the code Alen 10. Anyone uses this code during our online session, we'll make sure Up to Date reaches to them. Also, we are
Wow.
Yeah, I'll take care of that, Dr. Alen. I'll do that.
Thank you. So yeah, shall we get back? That was a good break, and yes, since our motive is to teach, and it should reach out to the masses, and many should benefit, and at the end of the day, the patient should benefit, and your practice should improve. Upskilling is our key. So, National List of Essential Medicines going back in India. Just a quick history. It is controlled by the Ministry of Health and Family Welfare, Government of India. First NLEM was 1996, revised in 2003. Then 2011 had 348 drugs, 376 just keeps on adding. But when some drugs are added, some are even deleted. I'll tell you the reason why. You may say, why not just add on the drugs? The category of the drugs, primary, secondary, or even tertiary, based on the base of healthcare and disease burden. So this is your NLEM 2011, 15, and even 2022. So yes, 348, 376, 384. Deletions 26, additions 34. We'll see which all have been deleted and which all have been added. So what are the practical applications of NLEM? So it helps in policy making, management, your own clinical practice, distribution, financing. You will understand how, if you have 2 or 3 drugs, which one to give, which will actually take care of the patient's disease. At the same time, it will not drain him of his finances. So even if you go to a medical practitioner, someday, God willing, you should not fall sick. But someday, if you have to go as a patient, you would want the best treatment with the minimal cost. Don't you agree, Dr. Ankush?
Yes. Cost is the most, most important parameter when it comes to healthcare. Most of us are not able to, we see in hospitals, Alan, that most of the people are not able to afford because of the cost of the healthcare. So cost is the most important parameter which, while we take into consideration regarding the drugs which are prescribed.
Of course, with the cost, you need to have the rational treatment for the same and the best possible treatment for the same. So the
Yeah.
purpose of NLEM, it guides your safe and effective treatment on priority disease conditions, and it promotes the rational use of medications and optimizes the available health resources of a country. This is for national, not just for India, but for other countries also. So it's a guiding document, especially for state governments, procurement and supply of medicines in the public sector, reimbursement of cost of medicines by organizations to its employees, and insurance companies as they must identify the must-know domain for teaching and training of the healthcare professionals. So, if at all you're starting your own practice and you're starting a small nursing home or clinic, definitely do refer to this NLEM, and you will have a basic already set down guidelines of what all drugs you need to have in your setup, and then you can apply for your regular licenses and accordingly. So now, how to read this NLEM list? I've just taken one section. There are multiple sections: anaphylaxis, abdominal problems, and cardiac, and like that. So if you're anti-allergics and just how to read this NLEM, you have the drug, you have level of healthcare, whether you should have it in the primary setup, the secondary setup, tertiary, and the dosage form or the strength that is available. Okay, so that is
Yeah,
very,
just
very
the
important for
strength, all the
centers.
strengths available. Yeah, that's rightly said, Alan. This is all the in the towards the right. These are the strengths which is available in the market.
Yeah. So Ankush,
Yeah, Dr.
over
Alan.
to the exciting part again. Yeah, we're
So
almost closing to the hearing, end of the presentation. I think Ankush, you should definitely chip in.
sure, sure. So we'll come to the next case scenario. You are working in an ICU of a tertiary care hospital. You examine a patient who was previously admitted with bronchopneumonia. There's a patient in your ICU admitted with bronchopneumonia. Next, Dr. Alan.
You can
So
also try controlling.
yes, I'll see. No,
Yeah,
I don't think I can control Dr. Allen.
I'll do it. I'll do it, Ankush. I'll do it. I'll do it. Yeah, on
So there's a
examination,
patient
patient
with
seems. Yeah, go ahead.
on examination, patient seems to be having a respiratory distress with the arterial blood gas showing carbon dioxide retention. So you examine this patient. There's a respiratory distress. There is CO2 retention. So you need to intubate this patient. Next, Dr. Allen. So you decide to go for an elective intubation. I'll say the previous case scenarios, it was an emergency intubation. It's a trauma patient. This is an elective intubation. Patient has bronchopneumonia, patient has respiratory distress. You have some time. So what drugs will you use along with the dosage? I want people to answer. This is an ICU setting. You have time. You are going for an elective intubation. So what drug will you use? Yeah, BP is normal. Yes, you can use midazolam.
Lovely, Dr. Trikul, very well said. Midazolam. Dr. Afan has also said succinylcholine. Can we use succinylcholine, Dr. Ankush?
The problem with succinylcholine is it's just a muscle relaxant. It will relax all the muscles. It will stabilize the patient, but the patient will be awake. Patient will not be sleeping.
Oh, that's scary.
The patient will know whatever you are doing, but he'll be not sleeping. He won't be able to do anything. So I see most of the people give succinylcholine directly. You have to use choline. I'll come to that point, but you have to give some analgesics also so that the patient is not awake. Suppose you give only choline and the patient is awake, your heart rate will shoot up. Yes, midazolam is one of the choices. Dr. Allen will answer this. It's a propofol. Propofol. IV propofol is mostly used. It's readily available. It has rapid onset of action. It affects your hemodynamic stability to a lesser extent as compared to the midazolam. So yes, we'll use IV propofol with muscle relaxant. The dose is 1.5 mg per kg of propofol. Now we'll come to the muscle relaxant. What is the choice of the muscle relaxant? Someone has said rocuronium. Rocuronium is very good answer, but it's expensive, not
It's
readily
expensive, yeah.
available, not readily available in every healthcare setup. Atracurium is good. Diazepam is not a muscle relaxant, Dr. Dheeraj. Paracurium, I guess its availability is an issue. I don't think it's available everywhere.
Not easily
Yes.
available in all hospitals. Atra is available.
Yes, cheapest is you go with Dr. Allen. I'd like you to move to the next slide. The cheapest
Yeah.
is you go with scolin, succinylcholine choline. Dr. Allen, next slide, please. Yes, propofol with scolin is the right choice, provided your patient does not have hyperkalemia. Choline is the right choice. These are other drugs which are non-depolarizing muscle relaxant like atracurium, vacuronium, rocuronium, which can also be used. Choline has the quickest onset of action, but you need to make sure that patient doesn't have a hyperkalemia. There's a risk of malignant hypothermia. Vacuronium, atacurium, these are all long-acting, mostly used in cases when we are giving GAS. Rocuronium is one of the drugs which is used for rapid sequence intubation. There's something called as rapid sequence intubation. So rocuronium is used, but it's not available. And plus, there are allergic reactions in some patients. So the drug of choice is propofol. You can use midazolam if you are not, propofol is not available with a muscle relaxant. Muscle relaxant ideally is succinylcholine. Next is atracurium. Vacuronium is the action is slightly prolonged. Like it takes a time to act. So I'll not recommend to use vacuronium. Rocuronium is a very good drug if available. You should rocuronium instead of choline also. Any questions for this?
I've just
Dr.
put a
Allen, I
question
hope
for
it
the.
was.
Yeah, I put a question for what is rapid sequence intubation. I'm just waiting for response.
Rapid sequence intubation is in this case scenario, you have a patient who is already in distress. So you need the drugs to act rapidly so that you can obtain a desired effect. So IV propofol comes under rapid sequence intubation with rocuronium or scolin. I hope it's clear, Dr. Allen.
So in words, sometimes when you talk to the anesthetist, they always ask for NP. The patient should be fasting for 6 hours solids, or maybe 2 hours for liquids. But sometimes patient comes in with poisoning or trauma. The patient is having a full stomach or had a dinner and then had a better accident. You can't wait for 6 hours to do a surgery. So in those conditions, use some method or something known as a rapid sequence intubation is used, where you clear the contents of the stomach, and at the same time you end up also intubating the patient. So that's a fast process. It's a very fast process. And so that is your rapid sequence intubation in very, very simple language. Okay. And
thank
Dr.
you so
Afnan
much.
says, I'm confused. So I'm just asking can you could put, what is the confusion part, Dr. Afnan, either personally to me or on the group, it would be beneficial to the other. In the meantime, let's move to the fifth case scenario.
So next case scenario, there's a 70-year-old male elderly. He's a diagnosed case of prostate CA. He's already diagnosed prostate CA. It's a slow growing cancer. He has metastasis to the lumbar spine. He's on a palliation treatment. He's already diagnosed. He's taking treatment. He's maybe on hormonal suppressants or he has undergone a orchidectomy. But now he has a continuous back pain. He's an elderly male. So he comes to your OPD. Dr. Allen, next slide, please. So since he's on palliation for cancer, he just wants treatment for his back pain. He doesn't want anything else. Because he's already taking treatment. So you are sitting in your OPD. He's taking a treatment from a high-end top institute. But he can't go back to that because it's a distant hospital. He just wants you to treat for back pain or maybe some other terminal conditions where you need to give just a palliation treatment. So what will you prescribe and what's the recommendations of WHO pain ladder? There's something called as WHO pain ladder. I can see someone saying tramadol. We'll not directly jump to tramadol.
Yeah, so just a quick word. So WHO pain ladder is a must-know thing for any general practitioner. It's just not for a tertiary care person. So wherever you are practicing, if you know the WHO pain ladder, you will be able to manage any kind of pain, whether it's an abdominal pain, whether it's any back pain. You just need to know the step-by-step ladder, and that's where the case scenario 5 leads to. Ankush, over to you.
Yes, I can see a lot of people are answering as paracetamol. Yes, we'll start with NSAIDs. NSAIDs will be the first choice. Salicylates like aspirin, paracetamol, Tylenol, all these drugs can be given. Or you can give NSAIDs like ibuprofen, indomethacin. These are the first line of drugs for pain management in WHO pain ladder. Next slide, Dr. Allen. Next, this is the WHO pain ladder. First step is NSAID. That's the previous slide, please. Previous slide. First
Yeah,
is this is the WHO pain ladder explained in brief. Step one is non-opioid analgesics like NSAIDs, be it paracetamol, be it etonocoxib, be it any ibuprofen, aceclofenac, diclofenac. Then we'll come to weak opioids. Weak opioids, codeine comes into this. Then will come, if still the patient does not settle with this weak opioids, we'll go ahead, we'll use strong opioids like morphine, tramadol, or a transdermal patch like a fentanyl patch. Even if after that the patient pain does not settle down, we'll go with nerve blocks, we'll go with epidural, or we can use pain pumps on a regular basis. This is what a pain ladder is for a terminally ill cancer patients, which is followed. Dr. Allen, next slide.
Yeah. So can you explain the two arrows? One is going up, one is going down.
This arrow says if the pain is not settling, we need to escalate. If the pain has settled down, we need to try de-escalating, because these strong opioids, nerve blocks, they have a lot of side effects. So if the patient's pain settles down with these drugs, we need to de-escalate, not continue that drug.
Right. Sure. Going to the next slide.
This is just next slide is just another representation of WHO pain ladder. Dr. Allen, can you move to the next slide, please?
So this is actually the actual guidelines. What you should do in step
This
1,
is the
step
actual
2, step
guidelines.
3.
Yeah, this is step 1. Again, salicylates, acetaminophen, NSAIDs. Okay, these are the drugs. Step 1. There's a what is called as a visual analog pain score. If a patient has pain 1 to 3, we can start with this step 1. If a patient has a moderate pain, you can directly start on opioids like codeine, morphine. Next step 3 is you can use stronger opioids if the patient has pain from 7 to 10. You should keep in mind this is for terminally ill cancer patients only. This is supposed to be followed for patients who are on the verge of death. You are just treating it as a palliation.
So can't we use this for other kind of pain? If your pain score, something known as a pain score is there, we calculate the pain score, say 1 to
People
3, or 4
do,
to 6, 7 to 10.
yes, Dr. Allen, people
Can
do
we use
use
that?
it, but the recommendations, the WHO pain ladder is just for cancer. We can use it, it's safe to be used for other pain, but other things, the thing is, cancer is not treatable. The metastatic cancer, which is not treatable, it's for that. For other things, we need to treat the cause. Suppose the pain is due to stone, we need to treat the stone, not give drugs to settle the pain. Yes, we
Excellent.
do need to.
Well said. You should control the source of your
Yes.
pain. Yeah. Sure. So just proceeding, and we're almost to the end of the presentations. So some drugs were deleted from the 2015, of which I would say bleaching powder, something atenolol, erythromycin, So yeah, some leflunomide, that's a DMARD, and nicotinamide, procarbazine, gancyclovir, ranitidine was deleted, sucralfate, white petrolatum, and something that were added into the NLEM 2022, amikacin, cefuroxime, glucocortisone, insulin, glargine. Then you have the latanoprost, montelukast, the rotavirus vaccine, niclotin replacement therapy, very well used. Ormeloxifene, centroman principle, that is mainly for, gynae uses it for period problems, and it's an OCP.
Dr.
Then you
Allen, I
have
want to
the
just
HIV drugs.
add on.
Yeah,
Dr. Allen, one of the most important drug which is added on is bedaquiline. It's an anti-TB drug which is added recently. So it's after amikacin, it's written there. So this is an anti-TB drug which is added.
yeah. So what is the criteria for including of a medicine? The medicine should be approved or licensed in India, understood. Then you should have robust scientific evidence. I'm just reading the summary of the same. And, should be useful for a disease that is prevalent in India. No point having a drug which is not having a disease in India. And of course, it should be enlisted in the national health programs or, disease control programs. And hence it will come in the list. Should be affordable to the community and readily be accessible to the primary, secondary, and tertiary healthcare levels. The cost of the therapy should be considered, and when there are same drug from the same therapy, more than one drug from the same therapeutic class, so one should be chosen which has a better efficacy, availability, and affordability. Now, how does the drug go out from the NLEM register or the NLM list is if the drug is banned in India. Concerns of safety profile is there. And if there's some other drug which has a better safety profile with better cost effectiveness, then the other drug will go off. Then, if the resistance pattern in terms of antimicrobials, which is a big problem faced, beginning to face in India, if that is there, then again, you need to, it will go off from the NLEM. So, this is one of the penultimate slides that we have. If you look at the treatment choices, how should you actually decide to give a drug to a patient? So you should look at whether your prior knowledge, okay, your first one, the green, prior knowledge. Then you look at the habits of the patient, social, cultural factors. So it's divided into intrinsic factors, societal factors. Sometimes the patient may not find it culturally acceptable to take that drug, okay, and authority of supervision, whether patient requires supervision to his drug. You can't give drugs blindly to a patient who's depressed. What if he takes off the entire drug, number of tablets and consumes? It will be a big problem. And how's your relationship with your peers? Workplace, how's the workload and staffing, infrastructure? Do you really work in a setup where you have, a good treatment choice? So all these things, and of course, very, very important, the scientific information about that drug. So all these intrinsic, societal, work group, workplace, and information all together put forward a treatment choice for this patient. Not just the drug, it's a treatment choice. I'm going to give A, B, C, D drugs to this patient. That is my treatment choice for this patient A. For patient B, it will be E, F, G, H, R. So that will be the treatment choice for the second patient. So that should always, you should have the factors that influence the use of medicines. So this is that's a snapshot of the same. If you keep this in mind, definitely it will influence your treatment choice. So what is the take home message? So we've tried to put it as essential. It's efficacy, safety and suitability, and storage, stability, ease of administration, that's in the dosage form, need for the population, total cost, irrational combination to be avoided, availability, and yes, listing regularly, that's updating. So yes, that's the take home message. Well, ranitidine there's a question on the group. So these are my references, and yes, there's a question on the group by Dr. Choyan. He says ranitidine is just deleted, question mark, question mark. Many are prescribing still. Yes, but this is our our understanding that we should impart knowledge to many who are there. So there are drugs that are banned
Dr.
or
Allen,
not being used much. Still, they're still being practiced. So
Yes, Dr. Allen. Dr.
of
Allen, I
which
would like to add
let's
on here.
yeah, go ahead, Dr. Akash.
Dr. Allen, to this question, I'd like to add on ranitidine is ideally supposed to be banned. It is found out it's a pro-cancerogenic. So it may or may not cause stomach cancer. That is why it has been deleted from the NELM list. But I think it's available in some centers. People do prescribe it because the information has not reached
It is
everyone.
available over the
But
counter also.
yes, it's available out over the counter also. We can't control what's there happening. But when you are prescribing, ranitidine is a pro-carcinogenic. It has known to cause uh, gastric cancer. So there is some association with ranitidine causing gastric cancer. So that's why it has been deleted by the government.
Yeah, over to Vijayji.
Thank you, thank you. So we are
A
opening.
wonderful, intense session, I would say.
It was indeed, indeed. As a outside, as a non-medical guy, it felt so informative for me. I can only imagine how this could be for all the fellow doctors around here. Dr. Dheeraj Nahar has one as a question. Dr. Dheeraj, please type the question, please.
Yeah, what is the question?
There is a Twinkle is asking, but sir, more or gastro prescribed famotidonide also. Sorry. Sir, can we use lingococaine with adrenaline in cardiac patient?
Yeah, ideally it is not supposed to be used in cardiac patients. Lignocaine with ADR is what you say, it's a relative contraindication. So you should avoid using lignocaine with ADR in cardiac patients because it can precipitate arrhythmias. So that's why in my case scenario, I mentioned the patient had a CAD, coronary artery disease. So that's why we should avoid use of ADR in patients who are cardiac patients. Sir, can we give amikacin in early pregnancy? Yes, we can give amikacin. I don't think, Dr. Allen, it's teratogenic to the fetus because I have
It's a
seen my
very, some places do, prescribe amikacin for,
it's renal
genital kind of
toxic.
condition.
It's renal toxic. It's renal toxic, I guess. But I have
But
seen my gynae counterparts using for UTI in this pain in pregnant females. What about
But
domperidone?
amikacin also can cause some, ear defects and all. But we're not very sure whether it can really be used in pregnancy. And there are places I have also seen my gynae counterparts being, using amikacin. So yeah, it's a very subjective thing, I would say. And of course, you need to read the safety profile, and all these many times these drugs are under study whether they are really you know uh, can it be this one. So usually they say it's amikacin may is not really recommended in pregnancy, but if you think the patient's life is more at risk of sepsis or anything, and you have to give, then it's always a risk versus benefit thing that has to be taken decision by a consultant gynecologist. Okay, so that we cannot really comment on that whether this one amikacin is really safe, right? But yes, uh, one question that had come: domperidone with combination of PPI. So what happened some time back? Government of India had actually banned these fixed drug combination with domperidone. What I remember. So because the safety profile was not very well studied. So that was the reason why domperidone with PPI or with as a fixed drug combination was banned. However, this domperidone as a standalone drug is still being used. So that is the thing behind it. Yeah.
There's a one question from Twinkle. Is opioid safe in advanced CA with liver mets as a palliative pain management? Yes, Twinkle, yes, I understand your concern that opioids are metabolites by liver, but we for the pain, these patients are already terminal ill. We have to give it. Again, what Alan said, it comes on the risk-benefit ratio. So we do give for terminally ill patients the opioids we do give.
Because you would want them to have a comfortable end. A terminal illness, you never know when the patient will die, and when you want to give the best possible care, at the same time you don't want to trouble the patient with pain and with all these problems, and you expect them to die in peace. So that is kind of palliative care, so that can be accepted.
Dheeraj has again asked, sir, which anesthetic drug we should use in cardiac patients for normal procedures like suturing? Dheeraj, you can simply use a normal 2% plain lignocaine without ADR. You can use that, provided you are not injecting into the vessel. Please make sure this does not go into directly into your vein or artery, because if it goes into vein, they might land up in cardiac arrest. So lignocaine, always aspirate before you are injecting it when you're using it as a local anesthetist.
And another thing about lignocaine, it should be given at the site of laceration. It should not be given IV. Let me just be very clear about it. Because in a high intense scenario, your staff, may just, okay, give that. You will be ordering drugs. Give that. Give this to the patient, and you would be, about to begin suturing, and you would say lignocaine de do. So what this lignocaine they though would say, okay, the staff might confuse it giving it IV. So always tell them to give it in your hand, and lignocaine is a drug that you should administer at the site of laceration or wherever you want to operate at that particular local site. Should not be given IV. There is an indication of lignocaine IV in arrhythmia, but that comes under the purview of the anesthetist or a cardiac person. Okay, so lignocaine is also, see, the thing about lignocaine is it can cause arrhythmia. At the same time, it's a treatment for arrhythmia also. So in a particular dosage, it can be as a treatment for arrhythmia. That is not the discussion here. So that has to be definitely taken care by the anesthetist or the cardiologist or the intensive care specialist.
Dr. Lakshya Bharadwaj asks, recently I saw dermatologists use ADR in severe skin infection.
I guess I don't know why he was using ADR for dermal infections. Skin infections are to be treated with antibiotics, not with ADR. Or if there must be a bleeding.
The other thing, yeah. So sorry to interrupt. The other thing about this thing about dermatologists do a lot of skin biopsies. You would have noted that you would have walked into the OPD when he was injecting ADR, and the condition you would have noted is some skin infection or some skin lesion. So a lot of skin biopsies are done under local anesthetic. So he would have been trying. We are assuming, we don't know. We are assuming that could be a biopsy thing that you would have noted, and in a patient with underlying possibly skin infection, possibly some other lesion that he's trying to diagnose. Ankush.
Yeah.
Dr.
Right,
Adnan is asking PCM in pregnancy. And Dr. Manisha is answering to it. Yes, we can use it in a limit like 5 to 7 days of intermittent.
Yes, we can use PCM is the safest drug to be used in pregnancy. We do use our gynae counterparts. They do use PCM right left for simple conditions in a pregnant female.
Provided the patient does not have any liver complications or liver disease.
Yeah.
That is very important. In those cases, you can't use PCM. You may have to go for some other drug, which is not metabolized by the liver.
Doctors, I have a question. I think you might have already answered this question, but still I would want you to shed some more light on this question. In your clinical experience, what are the most common misconceptions healthcare providers have about essential medicine, and how can you address them in a daily practices?
Sorry, can you come again slowly?
Yeah, sorry. In your clinical experience, what are
Yeah.
the most common misconceptions healthcare providers have about essential medicines, and how can they address them in a daily practice?
Yeah, Ankush, you want to go for it? Yeah. So the most
For this,
common, yeah,
I'll
okay, go ahead.
like
Go
the
ahead, go ahead, go
basic
ahead.
case scenario I discussed. So the basic case scenarios I've discussed is like the simple use of lignocaine, becamoride right left. So which the choice of lignocaine I'll say is with ADR, without ADR. I still see people are confused. ADR, when you are using, you have to see of the cardiac history. And if it's a end artery like you are operating, doing a circumcision, or you are doing a suturing on a finger, these are end arteries. So you don't use IDR, lignocaine within these. So this is how this national list of medicines is useful, determining what is the choice of the drug you take. Dr. Allen, anything you'd like to add on?
Yeah, the other thing about the most misconception is they think if they give too many drugs, then the patient can, or a long use of antibiotics. Okay, if a person comes to clinician A, he's given a set of antibiotics. Patient goes to the next doctor, he wants to give an antibiotic which is stronger than what he has given. And the same patient goes to the third doctor, he doesn't want to give those two antibiotics because it's already been given. He wants to give even higher antibiotic. So at the end of the day, these antibiotics do have a side effect. You should understand the rational use of medication, whether the patient really requires the antibiotic or not. Since he has already had 2 weeks of antibiotics, does he really require antibiotics or not? So that is the very important thing.
Yeah,
Yeah.
Dr. Lakshya Bharadwaj asks, patient come with severe psoriasis, then dermatologists use SC root ADR. Or I would want you to read once again, because
Patient has come with severe psoriasis,
then
then dermatology is using subcutaneous root adrenaline.
Yeah.
Push. The ADR
Maybe for a
specialist.
biopsy only. Maybe for a biopsy
Possible,
only.
yeah.
Possibly
To
because
confirm
ADR use,
psoriasis. Yeah.
subcutaneous use of ADR is, to confirm psoriasis, because psoriasis also has a different variety. So maybe that's why the dermatologist must be using. What about methotrexate Dr. Manisha is using? I don't know what question you are asking. What about methotrexate? Methotrexate is an anti-cancer drug. It is used by gynecologists for abortion. Dr. Afnan is asking, can we use atropine in cases of OPC poisoning if the patient has hypertension? Because atropine is usually given in bradycardia. Dr. Afnan, if the patient of OPC poisoning is stable, you just manage. Am I audible now? My internet connection is thoda unstable. Dr. Allen? Yeah. Okay. So we don't use atropine if the patient is stable. Atropine, it's written in books that we do give, but for all patients, we don't give atropine unless the patient is going into brady. Whatever I see my medicine counterparts doing, they don't use atropine. They do other drugs. They lavage the patient. So this is atropine. Unless the patient is having arrest, then they go for atropine. Dr. Allen, would you like to add on?
Yeah, perfect. I mean, no, you've really answered well, Dr. Ankush. That's a good answer.
Someone is asking, can we use tramadol in lactating women after LSCS? Dr. Allen, would you like to answer or should I answer?
See, many of these drugs have a class of risk, schedule of risk that you should always look behind. And this is not just for tramadol. Many of these drugs can, be excreted in the breast milk. The concern is not with the mother. Now, with the post-pregnancy, the concern is with the baby. So will the baby, really have the problem of, getting the tramadol and then, be more of a sleepy kind of nature? And so that is very important to note. So whether it comes in breastfeeding or not, it's a very controversial question. So
No, Dr.
not
Allen,
these are some drugs that are
tramadol,
not really regularly given.
these are, yes, rightly
Yeah,
said,
go
these
ahead,
are not
Ankush.
drugs which are regularly given, but tramadol can be given after LSCS because whenever post LSCS, the uterus is involuting. It is already reached up to the umbilicus, so it's involuting. So the gynecologists, obstetricians do use tramadol to suppress that pain due to the involution contraction. They do use tramadol. It is given, but considering the fact that there's a lactating mother, so you have to restrict it. Which they do use it, but in a restricted form.
Yeah, and there are certain studies over a period of time, the tramadol level builds up in the baby. So that is also because it's been secreted it, in some form in the breast milk. There are some studies, not all studies do say the same. The baby system and cause complications.
This Dr.
Thank you,
Afnan
Doctor.
wants to.
Great. Great. It was a great Q&A session. I think the questions are pouring in. Yeah. Doctor, I'll do one thing. We will continue the Q&A sessions, but meanwhile, I'll drop the certificate registration link on the chat box. People can now can go register for the certificate. Yeah. And we will keep the Q&A session rolling for more 5-10 minutes. Then I would want, if anyone want to come online and want to share their feedback about the session, please raise your hand. We will allow you to switch on your unmute yourself and switch on your camera. You can talk on in front of doctors and you can share your feedback on live. Thank you so much. So meanwhile, please go and register on the link to for your certificates. Certificate you will receive by next 24 hours. I think the questions still are pouring in, doctor.
Yeah,
Dr. Mogal Lalu is asking, sir, can we use lingocaine and ADR or both in hemorrhoids in OT?
Dr. Allen, I would like to answer this. Uh, this question, this
Yeah, go
session
ahead.
is on lignocaine ADR only, I guess. So, what is hemorrhoid? Hemorrhoid is a bunch of vessels. Hemorrhoids are bunch of vessels. You can't use lignocaine intravascular. This will cause cardiac arrest. So there's no point whether it's lignocaine with ADR, without ADR. They can't be used in hemorrhoids because hemorrhoids itself is a bunch of vessels. Yes, Dr. Allen, rightly said. So
You
please,
can't use the
we come.
injectable form. You can't use the injectable form, but there is this jelly that is commonly used left, right, and center. For lignocaine, that Lox jelly 2% that we use clinically. In
For
any
examination,
hemorrhoids case.
yes, we use
Yes,
it
for
for examination.
examination. And even we tell the patient you use it, it will you will be able to pass stools freely without any pain, mainly in fissures. It
But
locks jelly in
but
fissures.
in OT, you don't do this procedure.
Should be avoided. Yeah.
Plain lignocaine will help for saddle block for pain. Lignocaine is not used intrathecally, that we don't use it to inject in spine. No, please, these are wrong concepts, Twinkle. Lignocaine is not used for saddle block.
You use the lignocaine is a short-acting drug. You would want, since you're taking so much effort to give the drug through intrathecal or whatever, we would rather use bupivacaine or a longer-acting drug in the spine for spinal anesthesia, right? So why would you want to use lignocaine? There are some case studies where they even use fentanyl, but they
Yeah,
are, they have quite adverse side effects. Patient is having dizziness, recurrent vomiting. after giving intrathecal fentanyl. So that and all, there are some studies, but it's not really put it into, as evidence-based medicine. Shall we call it a day?
I think we should because I know the session is
We will have more sessions. We will definitely have more sessions. I think this was just like an icebreaker session to, NLEM, and it is just, we have only discussed 5 case scenarios. We have more to discuss in the upcoming sessions.
yes.
And of course, Dr. Ankush is the specialist in trauma and trauma-based, cases. So yes, we'll definitely request Dr. Ankush from his busy schedule to drop in and enlighten us all. So it was a great learning from for us from Dr. Ankush, and I hope if you could put a quick feedback. Even in the this one, the chat box, how the session was, so we will be able to modify ourselves better and and put forward more and more case scenarios that are related to your daily practice. So if you could tell in a quick this thing, send us emails, or can you just put your email, Mr. Vijay, so that we can tailor make our presentations in the subsequent days, how as per the cases that they see in their OPDs.
Sure.
Thank you, Dr. Twinkle. Thank
Thank
you, Dr.
you.
Shivangi.
Thank you, Mediversal. Thank you. Thank you for giving me this opportunity. Thank you, Dr. Allen, good old friend. Thank you. It was wonderful uh, sharing this session with you. Thank you.
Thank you, Dr. Manshu. Put in the mail, Vijay.
I have done it. So I have dropped the email ID of Mediversal Academy, contact@mediversal.co.in. Please.
So we also hold free, what do you say, when you're confused what to do next in life, in career path. So we also organize free career guidance. So you can always, and your career pathway may not be the same as us, this one. So that's why we are not able to hold it as a session. We hold it as a one-on-one email or chat-based thing. So you always feel free to talk to us and get enrolled with us, and we'll take you, to the best possible upgrade that's there and upskilling processes. Yeah.
I guess this is the important part because people want career counseling. This is called career counseling. What to do next?
Yes. So that this is where I would love to give a lot of credit to Dr. Allen ji, because Dr. Allen is always, whenever I give a call asking for a session to give someone who talks. We will get a lot of calls with respect to career counseling. So Dr. Allen sir will always be there, no matter how busy his schedule is. He always be there for our candidates, to talk to them on one-on-one sessions, sometimes over a call or sometimes over email, or most of the times on a one-on-one sessions through Google Meet or a phone call. So I would love to extend my warm welcome on that front to Dr. Allen. So, Dr. Allen Thomas, thank you so much.
Yeah. And the only thing is, usually it happens in the evenings because morning either I'm operating or I'm at work. So I like to have a cool mind before career counseling is a very very important sector, and what you decide and what you tell the person, how you counsel, and it's very important. So you need to always have a cool mind before. Can't be occupied with things. So the usually you can talk to them and take a time in the evening, and then definitely we will connect. And guide you in whatever possible way. And we don't charge for that. So yeah.
Yeah. It is completely free. The career counseling is completely free, and with subject to Dr. Allen's availability, we will make sure you will get a one-on-one session from Dr. Allen Thomas. And meanwhile, I'll come to the end of the webinar. But still, if anyone wants to come on camera and
Yeah, that'll be a motivation for us.
it would, because this is what drives us. Let me be very frank on this. This is what drives us
Yeah.
on a daily basis. Now, on everyday morning when we wake up, we there is a saying in India, Vaidyo Narayana Hari. So we indeed treat our doctors as our gods, and this is what drives us in every move, whatever we do. And even in our, whenever we sit for course development with Alan ji, that is what he emphasized that no, this has to be included no matter what the difficulties are. So that is how the course development session also start. So if you want, anyone want to talk, come to camera, talk about and give your feedback, we are
1 minute feedback. Yeah.
happy to do that. You can
And
raise your hand, and yes.
you'll have to give access, Vijay.
Yeah, I can do that. I can do that. Yeah, I have.
Somebody can raise hand maybe.
Yeah, yeah, yeah. I have given up permission. Or people can unmute themselves and talk now. I think people are shy. Cool. You can.
Maybe they just want the certificate.
Some more or less, yes. And also, few doctors, what I have encountered is people, they are in the front line to save lives, but when it comes to self, they will hesitate. Somehow they feel shy away doing these kind of feedbacks. I have encountered such things because doctors will never shy away. Like they are in the front line to save lives. But when it comes to promote themselves or to talk in front of camera, they sometimes find it little difficult. Nevertheless, we are coming up with one more such amazing course where you can excel in all the ways. Stay tuned. I'll drop our social media channels in Instagram links.
And please add all of them to our regular WhatsApp group so they get our updates. And,
Yeah,
and you please forward it to your peers and juniors. Let them also get access to this webinars and all, and it will be much helpful for them. And yes, definitely. Also, just want to add up to date. Mr. Vijay, can you make it free for all of them? Because what I understand is up to date is very expensive, and since they have really diligently attended this 1.5 hour session, I think we should definitely consider if they get enrolled with Mediversal, you should please give them completely free of cost this up to date subscription.
will do, will do, will do, will do. Alan 10
I
AM.
guess there is someone who wants to come up and talk to Dr. Allen.
Who's this? Where is it?
If you want, you can unmute
Rahul?
yourself. The permission is given. You can unmute yourself and talk to the doctors. Okay. I think
No one?
cool. I think
Sorry.
yeah, cool. So we
Dr. Rahul is there. Hey, yeah, Dr. Rahul, you need to
Hi, Dr. Rahul.
unmute you.
Unmute yourself. Unmute yourself. Can't hear you.
He can't unmute.
Really helpful, and I cannot thank you like more than this.
Yeah, Rahul, where
I
are you
do not-
working? Can you just quickly introduce yourself?
Yes, I am from Mullampur, which is nearby Ludhiana. So I'm working here as a MO. I completed
good.
my MBBS, so it's been 5 to 6 years. But this information was quite helpful. So I'm
Yeah.
really thankful to both of you.
No problem. Anytime,
Thank
Dr.
you.
Rahul, and definitely share the link with your juniors also for the upcoming webinars and your colleagues.
great, great, great. Thank you, Dr. Dr. Rahul. It was great having you on the show or talking to us. Yeah. So now let's come to end. I know there are, if we allow, there are a lot of questions will start rolling up, but due to the short of time, we will end this we will come to conclusion. Thank you so much, doctor, for this insightful session. I personally learned a great deal, and I am sure all the doctors here would agree with me. On behalf of everyone, I extend our sincere gratitude to Dr. Alen and Dr. Ankush. It is this kind of engagement and participation that motivates us to organize more such webinars in the future. And I am sure we will come back with these similar topics very soon, as soon as possible. Also, we are launching a lot of exciting courses. Please keep watch out for us. We are coming up with beautiful course where will help you on a daily basis. And thank you for all joining us today. We hope you have found this webinar informative and valuable. If you have any further,
thank you.
Would like to get more information, please reach out to us.
Thank you.
Thank you so much. Have a great day. Good night. Good night all. Thank you, doctors. Thank you so much.
Good night.
Thank you all.
Thank you, Mediversal. Thank you, Dr. Allen. Thank you, Vijay.
Thanks, everyone. You'll end? Will
Yeah,
you
I'll
end?
end. Thank you all. Bye. Good night.